Thank you very much for joining us for this PCR interview today. You recently presented your study on a model to predict clinical and economic burdens associated with the reduced access to PCI during the COVID lockdown. It would be really helpful for our viewers if you could summarise for us the key points from your trial.
So thank you for inviting me to discuss the study, Nicola. In essence, across Europe, we have seen that during the COVID pandemic, there was a big reduction in patients presenting for primary PCI in the setting of STEMI. And we hypothesised that this would have a major effect at the population level, both in terms of heart failure diagnoses, cost to society, and quality of life from the individual patient perspective. Therefore, we undertook this study to look at the UK healthcare system, where we have previously published a 40% reduction in primary PCI during the first month of COVID and the UK level lockdown, and to really look at what this means in terms of heart failure admissions, subsequently cost and quality of life. We used the Markov model to model this, and we used estimates from the UK literature to estimate the various different outcomes from having a delay in primary PCI or not even turning up for primary PCI. What we noted was that after a month of lockdown, with this reduction in activity, there was an average per patient, if you were admitted with a STEMI, of £166, which equates at a population lifetime level of over £400,000 cost to the healthcare economy. We also noted that there was a reduction in 1.8 life years and around 1.5 quality adjusted life years, which equates to a population level of close to 5,000 life years lost during this 1 month period and close to 4,000 QALYs lost. I think this is important data. Why? Well, because the methodology that can be used could be used across all healthcare systems, whether in Europe, where individual data from those healthcare systems can be used to replace what we have in the UK.
That's really interesting data. And we saw in the UK there were particular populations, particularly the Black and ethnic minority populations, that had poorer outcomes with COVID. Did you notice any such trends with your data?
So we didn't specifically look at this, but we have published quite significantly in this arena using other UK data. And the first thing to say is that yes, it has impacted the BAME community, Black and ethnic minority community particularly, in presentation with acute coronary syndrome. We found that the patients from a BAME background had a much higher probability of adverse outcomes compared to the pre-COVID era. We also noted that there was a marked increase in out-of-hospital cardiac arrests during the COVID pandemic, and this particularly affected the BAME community. Finally, we've undertaken more population-level analyses, not only in cardiovascular disease, but across all disease strata, so cancer, renal disease, diabetes care, and so forth. And what we showed was a particular impact of those patients which were at most deprived strata. And this has really been replicated across the world. And really, it's the sort of Hurricane Katrina effect, whereby the individuals that have the greatest deprivation are more greatly impacted by any such event, whether it be a natural disaster, whether it be a war, or whether it be the COVID pandemic.
Great, thank you very much. I think you've nicely shown us that the healthcare messaging of stay at home, which obviously was appropriate at the time, has led to significant health debt moving forward, and it'll be interesting to see how we recover from this. Thank you very much for joining us.
Thank you.